Welcome to today's webinar, the next in our Leadership Through Crisis interview series. Virginia Mason Institute is a mission-driven nonprofit education and training organization that helps organizations worldwide create cultures of continuous improvement. My name is Tad Akwat, and I'm pleased to introduce today's featured guests, Sue Anderson and Eli Quisenberry. Sue Anderson is currently the president of Virginia Mason Medical Center and the executive vice president of Virginia Mason Health System. Sue helps to oversee all patient care services at the medical center, as well as holding responsibility for finance, human resources, health resource services, information systems and support services, and maintaining the organization-wide focus on continuous improvement. Eli Quisenberry is Senior Director for the Virginia Mason Production System and the Kaizen Promotion Office at Virginia Mason Medical Center. He partners with leaders, staff, and teams across the health system, applying the Virginia Mason Production System principles as they work to transform healthcare and achieve the organization's vision as the quality leader. Chris Backus will be hosting today's webinar. He's a Senior Transformation Sensei here at Virginia Mason Institute. He leads improvement activities, workshops, and training for healthcare leaders and providers worldwide. By embedding innovative methods into the lean concepts he teaches, he works with clients to unlock the revolutionary thinking necessary to transform healthcare. You're encouraged to ask questions throughout the session using the GoToWebinar question tool. Today's session will also be recorded, and you'll receive a link to the recording and the Q&A transcript via email following the session. Thank you so much for attending, and I will now hand it over to Chris to begin the webinar.
Hello, and welcome everyone to our webinar. I have with me Sue Anderson and Eli Quisenberry. I do believe we had some sound issues starting with the introductory video. We're apologizing about that. We'd like to begin with just a little bit of framing for the work. So Sue, I'm going to go ahead and share my screen if you want to take it away and walk us through a little bit of some of the organizational structure that helps this discussion come forward.
Sure, thanks, Chris. Welcome, everyone. We thought we would start with our strategic plan because that's something that we start with every meeting at Virginia Mason with, which is grounding and aligning throughout the organization. Our strategic plan was developed in 2000 and has really served as our guidepost since that time for all of our staff. You could stop any person who wears a Virginia Mason badge anywhere in the organization and ask them to explain our strategic plan, and they would be able to tell you about this pyramid in their own words. And then as you go to the base of the pyramid, you'll see the Virginia Mason Production System. And really that's the foundation for everything we do. It's our kind of key way of doing our business. So yes, next slide shows our VMPS Journey, which actually began right after the pyramid was developed in 2001 as we started to learn about the Toyota production system. And then we formally adopted it in 2002 after a trip to Japan with our leadership team. And since that time, we've been on our continuous improvement journey. And it's not really important to go through all of the details on this slide, but to say that once you start, there's a lot of work that happens and that builds upon each other. So we'll talk about some of the key things as we go through our conversation today. So next slide. About 4 years ago, we had been talking with our senseis about how to take the Virginia Mason production system to the next level. And actually, Eli and I have been the people that have shepherded this kind of revitalization, or what we've been calling evolution. And out of that came a new house, which really describes our management system. And it starts with the Toyota production system principles that are down on that strong foundation, just like at the base of our pyramid. But then also incorporates some of the key work that we think defines healthcare and then defines Virginia Mason. So our Respect for People initiative, which we'll talk a little bit more about, the whole, the flows of healthcare and how they're different than the flows of manufacturing, and then our work on being the quality leader. And lately, what we've been really focusing on is speed. And that'll be a theme that comes out throughout this conversation, because clearly COVID has had us be working in warp speed. And Eli, I don't know, do you want to add anything maybe about this slide that you're thinking?
I think just the two sections we have down there would be the master the basics. So we try to continue to push ourselves on, eliminate waste, achieve flow, all the things that we know we've learned over the years, but then continuing to just weave it into our culture in some ways that you've already captured in that, like, make it your own top section.
Yeah. And then when you can see the strategic plan from the previous slide, because we always want to remind ourselves of what we're doing and why, which is our patient at the top, as we try to be the quality leader for them. Next slide, Chris. So this is Respect for People, which is one of those two pillars of our house. And our journey on Respect for People really began back in 2011 as we were learning in a safety culture how much respect is important to continuous improvement. We had a team at that point in time that identified these 10 behaviors as how we would know what respect looks like in our organization. And these principles have become part of our vernacular, and really people talk about these behaviors on a daily basis. We asked each person when we rolled it out with our mandatory training in 2012 to select 2 to work on. And the 2 I selected, just in case you're curious about that, was to be encouraging and express gratitude. And so those are 2 that I work on and remind myself every day that I need to be getting better at those 2 behaviors. And then over the last couple of years, we've spent some time saying, okay, now that we have this definition and we know what respect looks like, we wanted to go deeper, and we've really been talking about what does respect feel like. And really, I think that's the journey that we're on related for Respect for People at this point in time. Again, Eli, what might you add to this?
Nothing else at that point. It's great.
Okay, great. And then the next slide, just quickly, as we talk about our Virginia Mason production system, it really has 3 components. It has management by policy that we're actually in the process of renaming at this point in time as we go through our evolution. But really think about management by policy as help to provide the alignment within the organization. And as we responded to COVID and our work over the last few months, that's been an important part, is how do you keep that focus and alignment across the organization? But then how do you then implement it through cross-functional management and then also daily management on each Gemba? And the intersection of these 3 has been really critical and has been very obvious over the last several months for us. So I think that really is the brief intro that we wanted to put as kind of the grounding. Chris, I don't know, did you want to say anything else about kind of this section, or?
Well, I think maybe we could just talk about one question in this relationship. So the main ways the relationship between leadership and improvement teams work has changed a little bit as a result of COVID. And if it has, what has changed, and then how do we stay true to this this vision and alignment that you've talked about?
Maybe I can start, and then Eli, you want to jump in. But one of the things that we found is that management by policy historically has involved a more extended planning process, right? Here are our organizational goals for the year. Here's how they affect each work unit. Here's, all the way down to the individual person. And that takes time. And there was no luxury of time. On February 28th, we received our first patient in the hospital that was positive, and our world changed immediately in terms of what we were doing. And so management by policy was actually happening every single day. There was a core group of 7 of us who were meeting every single morning, first thing in the morning, to say what's new, what's changed since yesterday, what's our key work, and how do we want to provide that focus to the command center that was then dealing with the cross-functional management, situational awareness, what's the work that needs to be done across the entire organization. And that was only possible by the daily management, which does go on a fast pace every day. And it was much more visible all the way up the organization about what was happening on any individual Gemba.
Great. Now, Eli, we have some content to kind of explain some of the activities. Do you want to go into that content now?
Yeah, let me just make 2 more just brief introductory comments,
Sure.
and then I'll let Sue dive in a little bit on how the command center was running, and I'll complement that as we go. But I think the other 2 things that I would reinforce at this beginning is kind of thinking about a Kaizen promotion office, which for us is actually relatively small in our journey since 2002. And how do we think of ourselves in relationship to all of our leaders? And so if it's not obvious, something that we really try to purposely do is a decentralized model of Kaizen and VMPS across the organization. So KPO really finds ourselves in the role of training leaders, developing systems, and building kind of infrastructure and depth. And then COVID really highlighted the fact that all leaders and all teams are kind of able and expected to be able to improve their own work. And so then that really helped us achieve some of these elements of speed that I think we'll talk about a little later. But I think that purposeful development of a system and of depth across an organization has been paying off for years, obviously, and really was highlighted in this elements of speed. And so maybe we'll use that to transition into kind of what the command center looked like and how KPO interacted with it.
Great.
Okay, so this is our incident command, and over the time we rotated it among 3 of our administrative leaders, myself, Charlene Tachibana, and Kateri Chapman, and we were each partnered with one of our physician leaders because there were just so many clinical impacts of this particular incident command structure. So that's our chief medical officer and then other 2 people that are key in our senior leaders. And I referenced that there were 7 of us. So the 6 of us in this command structure, and then Gary Kaplan, our CEO, we were the ones that were meeting every single morning to talk about what was going on. And then we have a pretty well-developed incident command structure for any type of incident that might happen. And the ones that we really used this time that were different, and you can see them here on the chart, was really around the infection prevention, our clinical practice, standard development, and employee health, because they were critical and new to this particular area of focus. And then we have a strong support in our command center from our emergency management team that knows how to run a command center operation. And then early on, I think if not day 1, day 2, we said KPO needs to be at this table because there are just so many processes that are going to need to change. And we really needed those resources to be working with each of the areas as we identified the work. Anything you'd add, Eli?
I think I'll supplement it as we go forward. This is great.
So just jump in. So the next slide. So one of the elements of our management system is daily management. And this became very clear that it was needed in the command center itself. So some of those really important points are visual controls and daily accountability and what processes, and then leader standard work. And so we developed what is the daily management for this particular incident, because as we were rotating the leadership of incident command among the 3 leaders, we didn't want it to be different when Sue was on incident command from Charlene or Kateri. And so we had to develop what is our standard work, how do we go through the debriefs, how do we follow up, how do we interact, et cetera. And we had our incident command in a large room. There were lots of visuals, and I think we show some of them along the walls that helped to drive our daily management work.
I think the other key there that you're alluding to, Sue, is that, you know, in a crisis like this, we don't know what the business looks like necessarily. So
Right.
Often in the traditional structures, you go to the senior leaders for the answers, and this was one where everyone was learning as fast as they could all at the same time. And so kind of creating these visuals and structures allowed organizational knowledge to, you know, become centralized in a pooled set of knowledge versus relying on a bunch of experts.
And what was interesting about that, Eli, is especially early on in the whole COVID crisis, pandemic, every institution was dealing with their version of incident command and how they were responding, because most hospitals have that structure. And I spent a lot of time on external phone calls with other key leaders of the other health systems in the state. And I walked away from almost all of those meetings in the first month and actually said to Gary and others, we are so much better organized than other organizations are. And I think it's because we were quickly able to apply our tools and structure our work so that everyone knew what was going on, what our key priorities are, and what our current policies were around, you know, X or Y.
Next slide. That's just the remark there is, so that's mostly that reflection, Sue, is about the importance of each person in the organization having understanding of what is normal for their business, so that it was one, immediately recognize that we're in an abnormal situation, but the impact of any decision could be understood because people understood their normal. I think that's an important piece.
And there are so many moving parts and so many interdependencies. You know, we know in quality that a fundamental component of a quality culture is to have situational awareness and having everyone try to understand what that, I'm sorry, my screen just went blank, and having everybody understand what's going on so that they can question and adapt and change in the moment. And this was really important to that, is how did we let people know what was going on, because something that happened over here had a huge impact on an operation there. So when we first started, the way we did that is we had our senior ops huddle. That's the 7 people that I talked about every morning. Time enough, you know, early enough in the morning so we knew what was going on, but late enough in the morning that we had a chance to actually understand what might have happened overnight in terms of the situation. And then we had our formal debrief with the incident command, and people across the organization. And then at 10 a.m., incident command had usually about a 15-minute or so update to the entire organization. So all leaders were on a call where we said, here's the key things that have happened, here's the work for today or the work for the week, and here's what you need to know about. And then especially in the early days, we did another debrief, a formal debrief in the afternoon, because stuff was changing so rapidly that once a day was not enough. And then off of that, there were multiple sub-command centers. So we had a supply chain sub-command center. We had hospital patient placement command center, and so on.
Great.
Next slide. So here's some of the, you know, really very formal official stuff that we had up over on the wall. And so we learned early in our Kaizen journey that it is just really important to get things up, make it visible, and it doesn't have to be pretty. And so no one was trying to create this dashboard electronically that would let anybody know. We just knew that we had to dig in and take control of the work. And we had a lot of newspapers because there was a lot of work to do in that time. And then we did what a lot of places would do in any kind of incident command, but really making it visual around are we in red, yellow, or green status? And what was interesting about this is that the definitions changed continually during this time. And so really having the organization understand what each one of those meant. And you
That's
can see
an interesting, Sue, that's an interesting point that you make about things changed regularly, and it's that, you know, you do something and learn and then you go forward. I know Dr. Kaplan in the first series made a comment that, you know, people often felt like, well, yesterday you said this and now today you're saying this, and he said exactly right, because we reserve the right to learn and be smarter because of our efforts.
Right.
I think that builds trust, don't you think? With the teams, that we're willing to say this worked and we've learned and we're changing because of it.
And I think actually our whole Virginia Mason production system and our journey on continuous improvement has actually created within the organization a capacity to change.
Okay.
And which is needed in healthcare today and was definitely needed and continues to be needed in our current situation.
And the other capacity thing that I would link back, Chris, to your comment earlier about us reinforcing us knowing normal, is that we've learned, you know, especially we do a daily safety huddle well before COVID with our inpatient and outpatient units, that you only need to focus time on the areas that you're worried about. And so these types of visuals and definitions really allowed us to say, we don't have enough hours in the day to worry about all the things that are going just fine in a COVID crisis. Let's kind of isolate the things we need to pay attention to.
Great point.
Mm-hmm. Right. Oops, sorry. My screen just did a little jump here. There you go. Oh, there we go.
And so this is what I was referring to earlier about as we started to develop standard work for incident command in terms of how we would run our debriefs and other things. And you can see that by doing this, using yellow stickies, because things were changing so rapidly, we were able to keep track of the key areas. And then as the incident evolved, if you want to go to the next slide, this work evolved as well. So that as we had 3 times a week briefings, then how did that change from twice a day briefings, you know, as we kind of tapered down this work. And this is what we're currently doing here. And again, stickies. So, you know, the pink stickies are things we need to communicate out to the organization. The yellow stickies are work that needs to be done, and the purple stickies are work that needs to be done that we're worried about. So that has an and-on of sorts on it. And but this is really what's guiding us today as we continue to have our incident command open. We're currently only doing once a week briefings, but we're still using the same thing on the wall.
This is such a good example of the understanding of the method and the elements of the method, but not forcing people to, in a time of great, you know, immediate response, not forcing them into a canned tool, but actually using the concept and making something meaningful for the moment. So that it doesn't always have to be perfect and canned, and but the application of the method is really what the consistency that people can lean into. That's definitely a great concept. Eli, do you have anything to add there?
I think just maybe just overarching, I think thinking about where did our Kaizen promotion office group, and when I say that, I'm also thinking about kind of our more senior trained folks that have either been through the office or have been certified. That kind of, where did we kind of find ourselves adding value during this process? I think one Sue's highlighted is the kind of just the structure and organization of command center structure. So things would start with a mess, and the next day we would try to help the group make it more efficient. And I think that role of the leaders to just invite us in to say, we've seen what smooth running daily management looks like, and we know we're not there, but help us kind of nudge ourselves there. So I think that was one. I think, you know, the KPO group, just we found about half the group actually just kind of like more fully deployed into some key areas that really needed the combination of nursing and Kaizen expertise, or the combination of some logistics and Kaizen expertise. And then I think, like we often do, we found ourselves most needed in areas where there weren't clear ownership, for lack of a better word. So we didn't have, before COVID, screening stations for all of our patients and a standard way to replenish supplies. And so it was a little bit of like, KPO is a little more flexible and has some knowledge and can slip into this, or we didn't have a need for a full, you know, program managing all of our PAPR motors because we didn't need that many before. And so I think we found ourselves, I think, most valuable inviting ourselves or being invited into areas that didn't have an existing process flow ownership, for lack of a better word.
And then Eli, you've been invited back into areas as we have developed a new process and then it breaks down in some way. So our pre-procedural testing and making sure that the coordination between the lab and the clinics and the hospital is all working, because that's something that we had a little mini crisis with last week that I know you and your team became involved with.
Yeah.
Well, I think that's an important thing to call out. You touched on it a little bit, Eli, that KPO are not the only trained resources within the organization, that there's this leadership expectation that they are trained and certified in the method. And it sounds like you were coming in when additional expertise or additional problem solving and troubleshooting was needed. Is that fair to say?
I think that, and I think the other thing that became more obvious to us in this crisis than maybe ever before is just sometimes this mental capacity to step back and look at the whole, because especially in COVID, but I mean, our frontline leaders and teams that are running healthcare every day, they know how to improve things, but may not have just the capacity in the day to think about it. And so I think that's something that, our Kaizen office especially found ourselves able to come in and see things that were maybe would have been obvious to anyone that had, time to step back and look at that and really kind of see the whole. But then yes, definitely to what you said as well.
That value of the outside eyes.
Absolutely.
Just to get a little different perspective.
And then Sue touched on this a little bit earlier too, but I think this is not unique to our Kaizen promotion office, but how we try to develop all of our leaders is we don't want people just being an expert in their area or their kind of specific domain. So we really train and develop and give experience to all of our team members to see the clinic to OR connection, or the how does the lab flow fit into my clinical ordering process flow. And so we try to work hard on that, and that became even more obvious when the speed was needed to make some decisions that may impact lots of other areas as well.
Great. Well, we're getting really good questions coming in through the question window, so I want to encourage people to continue that. Sue and Eli, thanks for that framing. I think it helps. I think it will help people understand our overall approach, and then how we use our approach in response to this this COVID crisis, and really not moving beyond the crisis, but through the crisis, because like many places, we are still in the middle of it. Maybe just not as intense as it first was, or maybe some people are getting that intensity. I know some of our friends in Florida and some other places are really feeling that right now. We have a question from, let's see, from Devesh, who asks, how did you ensure the presence of leaders on the Gemba with the challenge of new infection control guidelines? So how did, I guess I'm inferring maybe, how did we make that safe for our leaders to be present on the Gemba?
So, early on, the infection control guidelines were changing all of the time, and we really had our leaders out and rounding much like we would any other time, but kind of on steroids, if you will, because we knew how important it was to be there for our teams. As we started to cohort patients, particularly, the positive patients with COVID, then clearly the guidelines changed there. And I would say that we're rounding in different ways to be mindful of the infection prevention requirements there. But, all leaders are capable of understanding what's the PPE that's required and what do I need to do to get out on the Gembas that I need to get to.
And then the other way, I think so there's the leader rounding piece, and then there's, I think, the group interaction with the huddle. And I would just say we had a very short window of a hiccup of how do we, for the larger group huddles, how do we do, some combination of virtual while maintaining that visual control production board aspect. And I don't think that took us much, probably like the rest of society, to figure out how to do interactions like this right here.
Right, virtual town halls and other things with people.
So Helen actually has a great question about, so the leadership presence and the communication. So her question is, how have your staff described the impact of the way you grew and developed the response? So kind of that kind of partner Sue on that idea of respect for people and sharing information. What was the overall impact from the staff perspective?
You know, I think in general, our staff all had the range of reactions to the pandemic that you hear and see in other organizations. But I would say that we had really good connections between kind of the administration of the incident and the clinical care that was being provided. And so we heard lots of stories in other hospitals about, you know, the leadership's not allowing us to do this, or is not providing us with the equipment that we need or to be safe. And I would say that it was probably much less here. That's not to say it didn't pop up from time to time, but as a general rule, I think we were very clear about what our supply status was, what the changing requirements were for keeping our staff safe. And I think they felt supported by the leaders because the leaders were present. They were able to ask questions. We gave them all the information that we had at the time, even if it wasn't complete. So I think the general tenor of the organization has been, you know, we're all in this together trying to provide the best care we can for our patients.
So Jan is asking a question kind of related to with the organization response. If items were escalated through the incident command structure, who owned the final communication to the involved stakeholders?
Great question. So things came in a variety of ways. We had a daily communication that went out to the entire organization. So a lot of the issues that were raised when we had something that we had resolved and could communicate, or the fact that it was still an open issue, through the daily debrief calls, we got the information to leaders so that they were supposed to get that information to their teams. We have a COVID site even today on our intranet so that people have all the resources that we've developed. We had a daily COVID communication that went out to all leaders that they could also distribute and or talk to their staff about. That's now down to once a week and targeted communications. But we had a function where the communications team was very critical to our command center structure. And so they were there at the table, and it was the incident command that was responsible for making sure that things got out as needed.
Okay.
Behind the scenes, the command center set up almost like a little mini flow station of, you know, someone's ideas and then the draft standard work and then who was going to edit it and then who we were waiting for approval on. And so it became real visible who's waiting for someone to approve this before it can go out, what's already been pushed. Are we on version 2 or version 20? And so I think we had, like anyone, some hiccups in those first weeks or two that we, you know, slowly helped get smoother as we went on.
So Arthur is actually asking a question related to you know, the collaboration across teams. So I think the synchronization, knowing the work, and actually, Sue, you talked about the impact of one team's problem or opportunity on others in the system. And he's wondering about how backlogs were handled. Let's say, so radiology or lab is pushed to a capacity, and recognizing the need to continue making sure that we're, you know, a safe place for our patients, and our patients are appropriately safe for care. How do we handle those bottlenecks at this time?
So I'm only thinking of a few kind of bottleneck areas. You know, one of them was in our pharmacy and prescription renewals that came in. So as shelter at home orders were coming in, people were advised to get, you know, 3 months worth of medications, which said instead of filling their prescriptions on some regular sequence, we had a bolus. And so that was one of the areas that we were monitoring. But our pharmacy team, through their daily management, knew what that was. I think we were only in red status a couple of days related to that, often in yellow until it got underway, but they had a plan, and really it didn't require incident command to manage. It was just the awareness of what was happening. And then I think, you know, especially early on, the testing capacity and the length of time to get our test results back before we were able to set up our own testing was really problematic. Our patients were safe. We just didn't have all the information that we needed to move them along in their care maybe as quickly as we could later on.
Right. I think there's a follow-on to this, in that, you know, listening and responding appropriately is key, but that sometimes takes patience, and the pace of the crisis is maybe running a little faster than the flow of respect wants to flow in the right way. So how do you reconcile that, or how have we reconciled that?
Maybe a couple of different ways, and then Eli, you can jump in. Immediately, we cleared our calendars, right? So we did not try to do kind of normal work during the early days of COVID. And so even if I were not incident command, I lived in the command center for the first month. And really, when I was in incident command, I was helping to shepherd some work that would support whomever was incident command. And so I think that's one of the ways to free up bandwidth when things are coming to you so fast. You know, I think the other thing that we've really, maybe about 2 to 3 weeks into the pandemic, we really started emphasizing how are we going to support our staff through this. So getting back to our respect for people behaviors, recognizing that people are not always on their best behavior in moments of crisis. But I think that our respect for people work allowed people to talk to others when they felt they weren't being treated with respect. And I think it also allowed us collectively to develop compassion for people and recognize, okay, I can see someone, you know, Sue's at the end of her rope, and somebody else would step in to help. And so I think that situational awareness was also helpful during this. I don't know, what would you add, Eli?
I think the other way we think, you know, we think our frontline leaders obviously play such a critical role in the spread of both information and respect, and they're really the ones that feel the crunch if they're getting mixed messages from the top, or if their staff are unhappy, you know, the frontline nurse managers, for example. And so I think the leaders and communication team, I think, really worked hard to develop, you know, huddle cards. We really worked hard to synchronize our flows of information, because if we were changing PPE standards, for example, every single day, and by the time you got the new standard, you'd already missed your daily huddle for the day, and so you had to kind of hurry up and scramble. And so I think there was a lot of work just to figure out what's the right order of information to people to get, and how do we have mechanisms to provide feedback. And that obviously wasn't smooth every single day, but I think got smoother each week as we had like the listening mechanism of where is it not working, and then the leaders were, I think Sue's done a nice job of articulating, the senior leaders were awfully synchronized every single day, so they weren't sending mixed messages unintentionally.
So we're getting some questions that kind of link to that that rate of information sharing. It's really linked to the rate of the amount of change, and there are quite a few questions here about how are we managing change, how do we manage change, and I think this. There are a few questions specifically about how the COVID outbreak has caused a rapid stress on organizations who aren't able to manage change so much. So there's some curiosity and I'm just trying to get some theme for the number of questions here. What recommendation would you have for people with the amount of change that's still occurring? You know, what would be some advice for them to take back to their organization about dealing with not only the rate of change, but the willingness to change at a time when change is almost mandatory?
A couple thoughts, if I can just jump in. We've talked a little bit about, I think our fastest cadence was like the daily change or the 2 times a day change. And I think as we've adjusted, I think the command center at some point made the decision that we just can't push out this. Well, one, the change was slowing down and we were becoming a little more stable. But then we said, you know, Wednesdays will be our key time to push out new standards. And so we actually were able to kind of meter the every single kind of point change improvement. And so part of it was, consolidating the messaging and putting it out in the same way. And I think our ability to have the capacity for all of our leaders to have daily management practices, to receive news, and having a standard way and structure that I deliver it to my teams doesn't make it panicky for me as a frontline leader to receive news and information and change. So those would be just some quick thoughts.
And I might add a couple things. So one would be, we talked about in our management system, the creating alignment or the management by policy part of that slide. There were a lot of questions with no clear answers. There still are a lot of questions with no clear answers. And the 7 of us who were meeting often dealt with those types of topics because we needed to make a decision and we weren't always in agreement. And so I think by having that smaller group where we could say, okay, but here's our decision, so that the rest of the organization didn't necessarily see that sausage making, helped with the communication downward. And, normally the 7 of us would not see each other on a daily basis, right? We're all off doing our own things. And yes, we have our regular meetings where we come together, but it was essential that we create that alignment at the top so that we, I've heard, great thing about leading through ambiguity is one of our leadership competencies that we've identified here. And leading through ambiguity is not how comfortable I feel in the situation of ambiguity. It's how well do I create clarity for my teams when things are unclear so that they know what path we're going down. And that was really essential during this time. And even today, I think where we still continue to have ambiguity is related to infection prevention. And I think that's just going to be an everyday issue for us. So we still do twice a week huddles with that leadership team and our infection prevention team. So this morning was one of those. We met and talked about, what mitigations, if any, are we still going to do in some of our physical spaces, not necessarily direct patient care, but in other areas, so that we're consistent across the organization and sending the same message to our teams.
There's a really good question from Arthur here about you had been speaking about alignment, and clearly the pace of responding to COVID has put a stress on the alignment. And you've just talked about how sometimes you're not perfect, but you find a way to work it out. It's in getting back to that, that agreement that will work together, the respect for people kind of at its core. But are there specific questions or reflections that can help pull people back to that that working together and that alignment? So, is there something that a leader does regularly, whether it's a question or a behavior, that allows the group to stay grounded and the focus to remain in alignment with our strategy?
Well, I mean, the easy answer for us is our pyramid, our strategic plan. And so it was very, very essential that we keep our patients at the top throughout this. So what are we doing to provide the highest quality care in a time when the patient care protocols are changing, because there weren't any when it first began. And then I think that our respect for people, which we pulled up, says that the impact on our team members is equally important. So that respect for people, for both our patients and our team members. And I think we kept that front and center the entire time, and continue to keep that front and center.
Yeah, so then related, but then, a little bit of a different direction too. I think we also, Sue mentioned, we dropped most just kind of regular meetings and, really solidified what do we want our priorities to be. But we also purposely kept a few kind of traditions for us. So our Friday report out, where all of our events and leaders usually come together to hear kind of what are the successes from a VMPS perspective every week. Through Sue's leadership, we made the first full decision that we're going to come together every week virtually, whether we have an event to talk about or not, and we're going to reinforce both a sense of normalcy, but also, VMPS is the way. And so I found myself in my office doing more just communication and reinforcement of, hey, there is VMPS and these types of skills happening all over this medical center, even if we're not seeing these big 5-day events. And so I think just capturing and spotlighting, hey, we know how to do this. We know how to see waste. We know how to run daily management. We know how to prioritize and communicate. And so, VMPS, I think it could have easily gone the other way if we didn't have kind of that maturity and depth. But we really leaned on VMPS as the way and the common kind of backbone and kind of common spirit on how we're going to capture this. So I think it gave us a little sense of normalcy sometimes.
Great.
I think that's true. The other thing I might add is part of our tradition is we have a Tuesday morning stand up. And so we've continued that going virtually, but once a quarter we get together and do more reflective work around what's happened over the last quarter in our VMPS work. And on April 28th, exactly 2 months after we received our first patient, was our quarterly stand up. And it was a review of some, not all, of the application of VMPS to the COVID pandemic at Virginia Mason. And anyone who went to that session or watched it virtually afterwards, I think was blown away by the breadth and depth of VMPS in all of our work surrounding this pandemic. And it was really a lovely opportunity to reflect, because when you're seeing it every day, you don't actually have a full appreciation for how much VMPS affected everything that we did.
So we're kind of in that 10-minute window. This is such a big topic, and the amount of questions coming in is I'm sure people would love to spend all day here. But let's shift focus a little bit to not responding to the crisis, but moving through and actually becoming the fully operational organization as best we can as we continue to move through the crisis. There are a few questions. Virginia Mason never abandoned all of its primary patient care work just to respond to the crisis, correct? We continue to try and maintain operations. And Stu, you had actually mentioned that there were a few times where we had to scale things back in order to make sure we had the right resources available, like PPE being one of them. But we're in a place now where we're starting to open up a bit more. In fact, we're opening a new clinic site on Monday coming up. So can you talk a little bit about how we're not letting go of COVID, we're staying focused on COVID, and we're also focusing on getting the organization back into its primary mission of serving patients, how we're balancing that tension?
Yeah, for a while, some of our operations were, quote, shut down under a governor's order that required that we not do certain elective services for our patients. But, patients continue to have strokes and heart attacks and need their cancer care and other things that, that's just part of healthcare and life. And those were always fully operational throughout this time. And it was really, how do we need to adjust any of those in the time of COVID? I think by the end of April, we were really coming out of the immediate feeling of crisis and knowing that we were moving into the new normal crisis. And I think that thinking has continued to evolve over the last few months. And now we're really thinking about how do we get even closer to normal in terms of recovering our operations, because there's a lot of pent-up demand. And then the other thing we're really dealing with is fear. There's still people that are afraid to come to the hospital, who really do need to come to the hospital. So we're spending time thinking about how do we recover to the new, whatever the new normal is today. And then anticipating what it might be in the fall. So continuing to do some surge planning exercises if in fact we do have the what could be predicted around the double whammy of flu and COVID later in the fall.
Mm-hmm. Eli, how about improvement activities? So I'm sure that some of the planned rapid process improvement events and Kaizen events didn't happen, but how are we looking at the work that people have planned and the new work that's coming from COVID, and also just getting back to operations? How are we managing that as well?
Yeah, so while we never officially said no Kaizen events or 5-day workshops, we certainly didn't see much for about 2 or 3 months there. So a number of events were postponed. A number of them kind of moved into kind of like what we would call inflow Kaizen. So they would come together for 2 hours to really get a boost of work going. And then what we're doing right now is we're trying to really support our teams with new kind of tools and ideas on how can you do semi-virtual and virtual events when it doesn't make sense to be a group together. We've got a pretty robust patient family partner volunteer pool that partners with us, and so we're figuring out which one of them feel safe to come in and which one of them do we make more virtual connections. And we're also just both reinforcing to all leaders and working with our senior leaders that this still is the method. We do want to get back to this, but we're really looking for our leaders to help kind of set the priorities for their teams, in alignment to many of the things that Sue's talked about. So in some ways we've tried to not change, and we are certainly being more adaptive as much as possible. And, for areas that have many staff on furloughs, we're not driving the same pressure that we might have. And for those areas that really need it, we're trying to respond with more speed than we could before.
Well, and I was part of some improvement activity during this time. I led some facility design work for a new clinic at the hockey center, with Seattle getting a hockey team. And we had to be very creative. So we took the fewest days possible to have a group of people together. We leveraged the remote, and then we, in order to keep our patient family partners safe, we brought them in virtually. And it's different. But it was enlightening. It was fun in parts. You're instead of asking the patient family partner to go over to that group for a minute, you carried their computer over to the group for a minute. So it's about creativity, but being clear on objectives, clear on process, and just finding, we talk about the 7 ways. So this one way is a live in-person meeting. Another way is a blended. Another way is purely virtual. So I think that is the creativity. So I'm wondering, a lot of the focus was internally running the business, but we also had relationships with our community care partners in the state and some of those boards. So how was that brought into this work as well?
And, I think Washington State has a pretty good emergency network process in place. And we've seen that because one of our hospitals is in Yakima County, which is one of the hotspot counties in the US. And so, we had daily coordination with them around what their needs were. It took a number of patients transferred out of that community just when they became at capacity. But there became a point where we couldn't be the complete relief valve. And so we've coordinated both through the Hospital Association, which is a fabulous organization in Washington State, and this emergency network, so that other hospitals could also help as our hospital in Yakima needed to transfer patients, as an example. Because in Washington State, all of the hospitals came together and said, we're not going to let any hospital reach crisis on its own. We're going to work together as a community to support each other and to support the communities, so that we will all get to crisis at the same point if that happens. And we're doing everything we can to avoid crisis. And we've been very successful. And my understanding is that there are other states that have not had that same relationship across hospitals, and it's created issues.
And I know the Institute, the Virginia Mason Institute, which is the support that we give to organizations outside of Virginia Mason with the same method and learning, we've been very active in supporting. I know over in the UK, we've had great opportunity to help them do small work to move forward through the crisis. I want to just end with some final thank yous, final thoughts. I'm just wondering if either of you, just if you had one sentence word of wisdom for people who are trying to moving through the crisis instead of being stuck in the crisis, what advice would you give?
I think two pieces of advice. One would be identify those tools that you're comfortable with and use them to their fullest. So the more that you can really focus and make things visible, and it will help with communication. And then I think my second piece of advice is really something Eli said, which is keep your rituals that you have that are really important to your culture, because as the pandemic is raging and people's response is raging, there needs to be grounding in the organization. And so identify what are those things that will help keep you grounded at the same time you're really trying to move forward with the work at hand.
Great. Eli?
I might just add on, I think the other thing that we're finding successful is, we normally have a fairly rigorous annual planning cycle and accountability each month throughout. I think we've given ourselves the grace to say what just isn't going to be on the plate this year. So of our priorities, which ones are going to help us through this new world, which is, virtual care, team member well-being, the types of things that we're going to work on those things anyway. We can boost efforts there, but then gives ourselves grace to say some of the stuff next year or when we can, when it makes sense.
So thank you both for your time. I think it's really valuable. I hope people value the conversation. We're going to just play a little recorded closeout for folks. But again, thank you for your time, and be safe, and keep the method moving. I guess Kaizen, Kaizen, Kaizen. Right? All right.
Thanks for
everybody.
arranging us, Chris.
Thank you.
Thank you.
And that is all the time we have for questions on today's webinar. Thank you, Sue, Eli, and Chris for the session today. As stated earlier, this webinar is being recorded and will be posted on our website, www.virginiamasoninstitute.org, under our resources section. You'll also receive an email with the link to the recording and Q&A transcript following the session. We also encourage you to explore more content on the resources section of our website, which includes case studies, articles, and improvement tools. And be sure to connect with us on Twitter, Facebook, and LinkedIn for news, updates, and upcoming events. If you're interested in continuing your learning, we have a variety of services to help meet your needs, including virtual training, coaching, and organizational transformation services. You can learn more at our website. Again, that is www.virginiamasoninstitute.org. And you may also email us at info@virginiamasoninstitute.org. Thanks again to Sue, Eli, and Chris, and to everyone participating in today's webinar.